So my name is Patsy Kelso. I'm the state epidemiologist for infectious disease at the Vermont Department of Health. Thank you very much for being here. I want to first mention that this session is being taped by RETN. And for those of you who are here, that's great. If you want to go back and listen to a particular part because you forget exactly what was said, RETN hopes to have it up and on its website by this weekend, so you'll be able to do that. And please spread the word for folks who aren't able to be here tonight that they should be able to see it by this weekend, or at least by Monday, I guess, on the website. Okay, we're going to take just the very first part of this hour or so and speak to you, give you a brief background of TB and what it is, to give you the basic facts. And then we'll talk about the clinics that are upcoming this week. And then we're going to leave the majority of the hour for your questions. So that's what we have planned. And public health nurse Sally Cook is not here yet, but we're going to get started anyway. So I want to introduce Dr. Kemper Alston, and here's Sally. So I want to introduce Dr. Kemper Alston. He's an infectious disease specialist at the University of Vermont Medical Center. He's also our TB consultant for the State Health Department. And I can say that in the last decade or more, I would think every case of TB that we've had in Vermont, he's been our consultant on it. So he knows about as much about TB as anyone in Vermont, certainly, and probably beyond Vermont. So I'll let Kemper get started giving you some background, and then we'll go from there.
Good evening. My last name is Alston, A-L-S-T-O-N, and I'm an infectious disease doc at UVM. And I've been treating tuberculosis cases for over 20 years, so been through this before many times. And I just want to kind of go over a few basics that might save a few questions, and then we can have a more general discussion. Tuberculosis is the issue, and it's a bacterial infection, which is treated with antibiotics. They just happen to be different antibiotics than what you've probably heard of because they're specific for TB. And the good thing is it's treated with antibiotic pills. Doesn't require intravenous treatment, and it's totally curable. One of the difficult things about it is it's a prolonged treatment. If you're sick with tuberculosis, it's 6 months of pills. If you've just been exposed but you're not sick, but testing shows that you've been exposed, then it's a pill a day for 9 months. So it's a big undertaking. TB usually affects the lungs, not always, but most cases affect the lungs. It's spread person to person through the air. And so what I'm sure we will find in general is that a lot of people haven't been exposed at all, and it means nothing to them. That some people have been exposed and might be carrying the bacteria and are at risk for getting sick in the future, maybe a 5 or 10% chance. And so that chance can be eliminated by taking a preventive antibiotic, a pill a day for 9 months. And hopefully we won't find anyone who's sick with tuberculosis. If you're sick with tuberculosis, then you take multiple pills each day for 6 months to get cured. A common question that I just want to answer right away is that if you've been exposed, but you're not sick, but you have been exposed, you're not a risk to transmit it to anybody. The only people who can transmit it are people who are sick with a lung infection and are coughing and spreading the bug that way. That's the only way you can spread it. So that's an important thing. The way we find out if someone's been exposed and infected or not is typically a skin test, a little bump on the forearm. It's read 2 or 3 days after the test is performed. And that's not detecting the bug, that's detecting your body's reaction to it. That reaction takes weeks, 8 to 10, 12 weeks to develop. So what generally happens is people will get a first round of testing to reflect what happened up until about 10 or 12 weeks ago, and then they'll get a repeat test 10 or 12 weeks after the last time they could have been exposed to this individual. If your second test 10 or 12 weeks after the last possible exposure is still negative, then you're off the hook. You never got exposed. And although it's spread in the air, person to person, it's not terribly contagious. Okay, so I've been taking care of TB patients for probably 25 years. My test is negative. Okay, it's not the most readily transmittable. It's easier to catch a cold, it's easier to catch a flu, it's easier to catch chicken pox. You really have to have prolonged indoor exposure to someone in perhaps a less well-ventilated room, someone who's coughing and putting a lot of bacteria in the air so that you get a chance to breathe them in. Okay, so it's not wildly contagious. We're hoping and assuming that most people who get tested will be negative. That's our expectation. That's usually what we find. If you test positive, showing that you've been exposed, then the next step would be to get a chest x-ray to make sure you're not sick with it. Some people really have not much in the way of symptoms, and so we have to get a chest x-ray to make sure you're not sick. If your chest x-ray is clear, but you have been exposed, then you will be offered an antibiotic pill once a day for 9 months to make sure you never get sick with it. Okay? Trying to think what else I need to mention.
Do you want to mention any differences between adults and children?
School-age children, I think the age of children here probably are at no risk, no greater risk than adults, and might even, some people think, might be even at less risk. There's sort of a golden era of school-age children who just genetically and constitutionally seem to be at less risk for getting sick when they get exposed to TB. Very young children, less than 5, conversely, if they get exposed, they can develop active TB quicker than adults. And so there'll be some urgency to get people tested quickly, especially kids who are less than 5. Adults can carry it for decades and decades without being sick at all. Normal chest x-ray, don't know it, and then develop it later. For an adult, the lifetime risk of getting sick with TB, if you've really been exposed, is 5 or 10%. So 90–95% chance nothing happens to people anyway. There's no vaccine for TB. There is a vaccine used around the world, but it doesn't work very well, and we've never used it in the United States. So there won't be any vaccination as part of this. Testing for TB is not routinely done for everybody in the United States because the rates are so low. So most of you, all of you in this room probably have never had a TB test. For many of you who end up, the assessment is you have been exposed to this person, then you'll probably get your first TB, maybe for many of you, the first time you've ever been tested for TB in your life. If you've worked in prisons or hospitals or other places where testing's done, then maybe you've been tested before. The key distinction is between those who have been exposed and truly infected, but they're totally asymptomatic, chest x-rays clear, they can't spread it to anyone. We got to find those people and prevent TB by giving them 1 pill a day for 9 months, and make sure that the people who have been exposed are not already sick with it, because that requires a little more treatment. And that it will be based on how you're feeling and what your chest x-ray shows. The typical symptoms of TB, usually it's in the lung. So the typical symptoms are cough, fever, night sweats, weight loss. Hard to tell this time of year when everybody's coughing and a lot of people have fevers. Flu doesn't show up on chest x-ray like TB, so that'll be a key distinction. Vermont, usually, another question we sometimes get, Vermont has usually somewhere between 3 and 7 or 8 cases of active TB disease, people sick with TB, every year. There are many, many more than that, obviously, who are carriers. And we treat a lot of carriers in Vermont to protect them and to prevent them from getting sick. But for active disease cases of TB, like what we're concerned about here, we usually have a handful per year in Vermont. In the United States, there's 9,000 or 10,000 active cases per year. Vermont's among the lowest risk states and lowest risk in the world for tuberculosis. So it's very uncommon here, which is why you all are probably not very familiar with it. So it's only spread by someone who's sick with it, who's coughing, and doesn't cover their mouth when they cough. So when they cough, they put bacteria into the air, which other people can then breathe. Usually in smaller rooms than this. In a big room like this with a high ceiling and fans on, if I had hideous tuberculosis right now, none of you would get infected. None of these bugs would make it all the way deep into your lung. But if we were in a small, low ceiling, poorly ventilated room for a long time sharing air together and I was coughing without covering my mouth, some of you could breathe that in and get exposed. And again, even if you get exposed, 90–95% chance nothing ever happens. But to prevent that 5 or 10% chance, you'll be offered a medicine. It's a pill a day for 9 months. And then you're done for the rest of your life. No more TB testing, no more x-rays, no more nothing. Maybe I'll stop there in the interest of time.
So Sally Cook is our nurse epidemiologist who also has lots of experience with TB. Before she came to Vermont, she was in South Carolina? North Carolina, sorry. Where she was a public health nurse and has worked on lots of TB investigations, done lots of clinics, just like we're planning to do here next week. So she'll talk to you about what the clinic's going to be like next week, and then we'll open it up for questions.
Hi, Sally Cook, public health nurse, and thanks all for being here. I'll just speak for a couple minutes and then leave lots of time for your questions. So the plan right now, and a lot of this is still in progress, but we do have kind of the basic framework set up now for our first TB skin testing clinics that will start Monday. So the first clinic will be here on Monday. It'll be staffed by public health nurses from the Department of Health. We've all had experience and education and training with placing TB skin tests and interpreting them, and working with people of all ages, babies, children, and adults, with placing TB skin tests. So, and we've also had experience with doing large clinics like this. So again, the plan is for the highest risk target group of students and some adults to be tested at the first clinic on Monday, and then we will come back on Thursday to the school to check the site where the TB skin test was placed and read and interpret any reaction to the skin test. There's no need for any action in between those days. So again, we'll place a test on Monday and then come back and read that on Thursday. We'll set up, just to give you a real basic idea, I think, are we in this room? Okay, so we'll be in this room. We set up the best we can to have things be very organized and calm and have, you know, a reasonable amount of privacy. And I think it's the Burlington district staff and the school staff are working to get the setup in place and make sure that we are as organized and that it runs as smoothly as possible. There is some paperwork that has gone out or that is in the process. The obvious things like your authorization for us to do the test, the confidentiality statement that we're required to get from you. So the paperwork is really important. We do need to have both of those papers signed and returned to us for the clinic. So we really appreciate it if you could take care of that. Other Details about the clinic, I think that's about it. Okay, thanks, Kemper. So, right, very important. So, if someone has what's called a positive TB skin test, and that would be if you're talking kind of in a little bit of a clinical way, what will happen is when people come back on Thursday, we'll look at the skin where the test was placed. We'll measure what's called induration on the arm. So we'll have millimeter rulers, and we'll place those on any induration, which is a special type of swelling, little bump that can occur 48 to 72 hours after the skin test is placed. So we'll measure that induration, and depending on the size of the induration, if there is any induration, we'll then interpret that as a positive skin test result or a negative skin test result. Anybody who has a positive skin test result will refer for a chest x-ray, and the chest x-ray, you know, should be done fairly soon, but it's not going to be an emergency in somebody who has maybe a positive skin test but otherwise is doing fine. Those who have a negative skin test this time, we will come back in 8 to 10 to 12 weeks and repeat the same TB skin test at that time and interpret results again at that time. The reason that we do the second round of testing is that it can take up to 8, 10 to 12 weeks for a person's immune system to begin, you know, recognizing the TB infection if it occurred. And so by doing the first test, you have that, what we call kind of a baseline result. And so anybody who's positive with the first round would get a chest x-ray and be considered for preventive antibiotic treatment like Kemper mentioned. And then, anybody who's negative will retest again in a couple of months, and that would be you know, the last tests that would be needed for these individuals. We aren't, so I'm sure we'll have some questions about this evening, but again, we are working to try and identify the highest risk individuals first, and part of that is based on the amount of time that a person might have been exposed. Part of it is based on the age of the individual who might have been exposed. So there's a number of factors that are going into that decision, and we'd really just ask you to be patient with us while we work to really prioritize people in a kind of a step-by-step way. Any other key points? Okay. Okay, thanks.
Stay. So your questions for any of us? Yes, sir.
So for those of us who got the second email,
Yes.
indicating that, it's terrible to go first. So for those of us that got the second email, or do we assume that they have been already been placed in the higher risk category? Is that the deal? So there's no more assessment to be made then for those?
Right. So everybody in this school got the first email, and 140 or so people, parents, got the second email, which said that those 140 or so children have been identified as in that highest priority group for testing next week. So that assessment has been done, and we're testing those 140 or so children and adults on Monday.
Hi, I'm just wondering how you decided who should be amongst that group being tested, and when you are going to make the decision if other people should get tested, part one. Part two is, I feel as a parent that I have the right to know a little bit more information to make my own decision whether my child should be tested, and without knowing anything about who the person is, what part of the school, anything like that, I'm really clamoring for some information.
Okay, I'll start, and probably Sally can add to that, to what I have to say. So we worked very closely with the school. We know who the individual is, and we talked to the school a lot about who that person is and what their activities are, what their roles are at the school, who they're involved with, who they interact with, all the various groups that they interact with at the school, to what extent they interact with them, whether they spend lots of time with them or just a little bit of time with them. We had lots of conversations about all of that. And we've done this lots of times where we've identified cases and done this type of contact tracing to identify who had an exposure to that individual and determined who needed testing, whether it's in a household or in a social group or in a setting like a school. So we feel very confident that because of all the discussions we had with the school and the experience we have in doing these types of investigations, that we've identified all of the highest risk individuals in the school, and that's the 140 or so. We also recognize that as parents or individuals who work here at the school, you may disagree with that, or you may be anxious, or you may want testing even if you're not in that first group of 140. And you're, of course, free to take yourself or your child to your own healthcare provider for testing. We would ask that you, and you're free to talk to your own healthcare provider about it, of course. You can stick with our plan, which is we'll test this first group. Once we have the results of this first group of testing, depending on how many, if any, are positive, that will help us determine whether we need to expand it and test more individuals associated with the school, or whether we don't think we need to test any more associated with the school. So we determine that based on how many, if any, test positive in this first 140. But we know that there will be others beyond 140 who want to be tested, and so let us do this 140 first. In a week or two after that, once we get this first most important clinic done, we will come back and offer a second clinic for those who weren't in this identified group but do want testing. So we will provide that at no charge, but we need to do this higher priority group first. If you want to pursue testing on your own in the meantime, you're free to do that. Anything you want to add? Kemper?
I guess I would just say if for people who get testing outside of the Department of Health system, I would ask, your choice, voluntary, but to communicate with the Department of Health about those results, because that will be more information that we can learn from and perhaps save you redundant testing that we would do. So if you learn anything about this that we don't know, please tell us.
Yes. So the question is, how long might the person have been working while they were symptomatic? And that's been part of our investigation, and that's, we feel like we know the answer to that, and that's been part of our determining just who was exposed and who needs to be tested. We think the individual was potentially infectious for the school year, this school year. Excuse me, there was a question over here first. There was a hand raised over, no, I think the gentleman in the dark coat. Did you have a question?
If I understand the question correctly,
How quick does it have to happen for safety, yeah?
Right. And for a
first question, so if it's already been a full semester, if it's been 3 months, do you need to get on preventive medicine within 1 month of exposure, or 3 months?
right. So if the skin testing is positive, then you need an x-ray. Nobody goes on any kind of medicine without an x-ray. And so we would hope that the x-ray would be done, expeditiously in the next day or two, or whenever someone can get an x-ray. And then if the x-ray's clear, then you would go on treatment. So the x-ray result would have to be read that day, and then presumably the following day you would be offered medication to be treated. For adults, the only x-ray will be if you're positive, if your skin test is positive, either on the first round or the second round. And just remember that the final testing won't be for 8, 10, 12 weeks in that range from the last exposure. So we will have to work with people to figure out when that will be. So the baseline testing on Monday, will reflect whatever exposure someone could have had up until 10 weeks ago. It takes a while for the immune system to express a reaction to the bug. So I know it's quite confusing, but I can try to clarify it again.
Thank you. How did you discover that the individual has TB, and how long has the school system known about it?
The case was reported to the health department over this past weekend.
So, like last Saturday?
I don't know, I think it was Sunday, it's Sunday.
4 days before 3 days before you notify parents.
Something like that.
So let's either yes or no. Time is a definitive amount of time, so it's either yes or no.
I'm not sure exact, I think the letters went home yesterday, which was Wednesday, so yes.
How long has this person been away?
How long have they been aware?
Sunday.
When was the person's last day at the school? Are they still in the school?
They're not still in the school.
When was their last day?
I believe Friday, but I'm not 100%
Who would
sure.
know that? Audrey, you know that, right? You should know that, you're an employee.
I don't know that for sure.
How can you not know that you're an employee?
I don't know exactly which of those were in or out on Friday.
Well, isn't this an important thing to know? Employee that has TB?
You know, whether or not the individual was here through last Thursday or last Friday is not so important since they were.
We're establishing protocol and how things have been handled correctly or incorrectly, and how they're continuing to be held incorrectly or correctly. I have 3 kids in the school. Nobody contacted me about which kid, but other parents that actually heard rumors that were started by an officer at the school. So there's some protocol questions as well as the technicalities about the risks that our children are at. There's 2 different avenues that need to be explored. And I understand that you're here from a health perspective, but as parents, we're here from both perspectives.
Can we have a separate meeting on that then, please? Because I'm here anyway to learn about the health part of it. So
Okay,
if you're angry, if you have problems with the administration, can you contact them?
There was a question in the middle, I think. Yes.
Hi, yes, I would like to know when the person will be allowed to return to school. Can you determine that they are free of the bacteria?
So the question is, when will the person be determined to be cleared of the bacteria and be permitted to return? Do you want to take that, or do you want me to?
The person's being treated, and and again, this only pertains to people who are sick with it, because those are the only ones who can transmit it. For people who are sick with it and being treated, from the very first few days that you start treatment, your risk to others begins to drop rapidly. But as a precaution, generally, people wait at least 2 weeks. I think in this setting, since they'll be returning presumably to a school setting, that will probably be longer. I would think it would be probably a month or more or less. We can do follow-up testing on the individual to document that they've responded to treatment and that the number of bugs that they're coughing has been reduced. And so that will be a judgment, a medical judgment based on how the person's doing the treatment and how they're responding to treatment, but it'll be weeks.
Okay, thank you.
Yes, you, sir.
Right, so, sort of question about protocol. You know, you mentioned that people might not respond positively to a test even if they've been exposed and are harboring the virus, because it takes time for the body to reflect that in a positive test. So in between that window, the 8, 9, 10-week window, what's the protocol for somebody who becomes ill? Undefined upper respiratory illness, do they come to school? It could be the flu, it could be tuberculosis. Have you given the administration guidance on what to, what to recommend?
You know, I think that'll have to be done on an individual case-by-case basis. If someone didn't, I think you're asking if they didn't test positive on the first round and they're waiting, say, 2 months for the second test, and they become ill, I guess they would need to see a medical provider, and if the medical provider was concerned and didn't think it was just a cold or their flu test was negative or whatever, they could always get a chest x-ray and just document that their fever is not due to tuberculosis.
Right, but if you leave that up to individuals, someone with tuberculosis might not go to a provider. Their provider might have the background information that would lead them to a different diagnosis than they might otherwise make.
Right.
And I think given that none of the administration are health professionals, they'd be looking to you for some protocol, not just leaving it up to individual parents.
Right, that's a really good question, and I think, to some extent, it does get back to basics, while it's going to be really important, as Kemper said, to seek, medical attention, as you would anyway if your child is sick and not getting better. I think that's what's important to pay attention to. So in other words, we at the health department, we always recommend that in the school setting, a child with a fever and cough not be in school with a fever and cough. And most of the time, and this time of year, a lot of people have a fever and cough. It's flu season. So in most of the time, that's going to clear up in a few days or a week or so, give or take. But if you as a parent, see that your child is ill per your routine, then we would recommend that you, get medical attention per your routine. And understanding that there's the additional concern of the exposure to tuberculosis, it's still much more likely that that illness is going to be some other, prevalent seasonal illness. But you're exactly right that it's important for sick students and sick staff and adults not to be in school while they're sick. So yes.
Did you have a follow-up?
Just a quick question. Was this a drug-resistant student or is this not drug-resistant?
I'm sorry?
The index patient, is that a drug-resistant form of tuberculosis? Or not?
We don't have that information yet.
A preliminary test suggested that it's not, there was a rapid preliminary test that was done to show that it's not resistant to one of the common drugs, which resistance to that common drug is a marker oftentimes for more resistant strains. That looks sensitive. So that, and there's no suggestion from the individual's history that they would have a resistant strain. For example, they haven't been treated previously. So those tests take a little time. They're not back yet, but there's no evidence as yet, and a preliminary test on this one drug is very reassuring. In the United States, very drug-resistant TB cases account for about 1% of the total. So it's pretty darn uncommon anyway.
Yes.
If this individual has been symptomatic since the beginning of the year, which is the end of August, isn't there a chance that they've already infected people at the school who may also be symptomatic right now and continuing to spread the infection? And what are you doing about that?
So that's the point of testing and talking to people. And obviously there's going to be, starting tonight, a heightened awareness of this, obviously. So that's the whole point of when the clinics are done and people are tested, there'll be questions about symptoms. I mean, part of this is to find people who have just been exposed so that they can be offered a medication so they don't ever become ill. And a second part of this will be to make sure that there's not someone who's already ill. And again, if your skin test is positive and you get a chest x-ray and the chest x-ray is positive, then that person will have to be evaluated to see if they're already ill. And if they're already ill, they'll obviously be kept out of school.
Okay, but the communication was quite vague in terms of what exactly was going on. And to Eric's point, there should probably be a follow-up email with more specific symptoms or things to be aware of for parents to track, because not every parent is here today, and it's a pretty serious disease that people should be more aware of if there's possibly more kids infected or adults.
Thank you. Okay, over here, the lady with the blue jacket, I'm sorry, I saw her earlier.
Will you be sharing the results with everyone widely? Will you be saying, thanks. Will you be sharing the results widely? Will you tell us, 10 children tested positive, so that we all have a sense of what's going on and how to take the next steps?
Yes, we'll share aggregate results. We will not share individual results, but we will share aggregate results so that the entire school community knows how many tested positive, how many tested negative, that sort of thing.
Okay, thanks.
So if our child tested positive, the parent would be notified by email or?
So the plan is to notify you at the time of the reading of the skin test. So we'll need to have your contact information, cell phone or whatever, so that we can do that and let you know.
And how involved can or should parents be in the testing? Like, on Monday, can parents go with, their children? Should parents be here? On Thursday, when tests are read, should parents not be here? I mean, how is the actual, what is the day going to actually look like?
Right.
And how is that going to be explained to our kids? How are the teachers going through what's going to happen, with these tests? Is that our responsibility as parents? How is that going to be relayed to the kids?
So, do you want to say anything about that, Sarah?
All right.
Sarah Moran is our school nurse liaison for this district. And yeah, that's really important. I'm glad you brought that up, and that is something that we're working on right now as we speak for some additional information, fact sheet, to explain for the children.
Appropriate information.
So if I understand the question correctly, you want to know what information are the children going to be given, and if they're going to be, how is the test going to be explained to them, and what is the parent involvement? As far as parent involvement, let me just answer that question right away because I know the answer, and that is, yes, the parents are welcome to come. The test itself is a very small needle that injects a very tiny amount of fluid underneath the skin. It actually blebs up, looks like a mosquito bite. It's not very painful. It's just a teeny little prick. And we will be sending home information on how to take care of the site. The one thing you don't want to do is squish it and push the fluid out. So second
One
question. Yes?
about that specific. Does it look like a syringe, or is it like a
it's
a
a very
prick?
tiny, it's called a tuberculin syringe.
Yeah.
And the needle is very short because we only have to inject it a teeny weeny bit underneath the skin. Okay. So it's not a big syringe. It's not as large as a syringe that you would use to get a vaccine. It's smaller.
So it's not an injection, it kind of goes in horizontally.
Yeah, it goes
into the skin. Not into the skin, and therefore when you inject into the skin, it makes a little bump right away. And then 2 to 3 days later, you come back and you show the nurse your arm. And that's how it's read. So it's, on the scale of things, it's rather simple.
So it actually goes in between the layers of the skin. So your epidermis, and then there's the dermis. They slide it in between the layers of the skin, inject a small amount of fluid. It raises up slightly. It's about the size of a pea. There are other things that they haven't discussed yet. It will itch. Sometimes people react to the medium. So it sometimes could be, I don't know, it's an albumin medium that it's
a protein derivative.
Protein, yeah, and some people will react to it and get itchy. Don't put Benadryl on it, because that...
I will be sending home instructions on how to make, I mean, it's not a big deal. It's just, you don't want to press on it, you don't want to put a Band-Aid on it, you don't want to scratch it or in any way.
And then...
You'll pretty much not notice it after a little while unless it does. For some people it's itchy, but not for everybody. So the other part of your question, we need to work on some information that will go out with the parents. I don't believe we have that yet. But it's not even as dramatic as getting a vaccine. It's a very simple little test.
If your kids are phobic to needles, you will want to be there. If it does not hurt as much as an actual vaccine shot, but it is a fairly graphic thing where the needle goes in and suddenly there's a bubble on the skin. So if they're already phobic, you might want to consider being there.
So if you want to be with your child, that's fine. You don't have to. It's really not a major situation. And if you want to be there when the test is read, that's fine too. But if you choose not to be or not able to be, and it is a positive test, you will be notified right away. Also, your provider is going to be, will be sent the results of the test, whether it's positive or whether it doesn't show anything at all.
Yes. I just had a follow-up to Eric's question about if you become symptomatic between now and 6 months, in the future. Would there be any benefit of getting tested for TB, doing the Mantoux test, if you become symptomatic, whether you want to find out whether it's the flu or if it's TB? Are you more likely to have a local reaction if you're showing symptoms? Just to rule out that it's not the flu or not the cold. If you're symptomatic, are you more likely to have a positive reaction if it's TB?
Yeah. If you're sick and symptoms, that means you have TB disease. It's already progressed to having disease. So you would have think that your skin test would long since be positive by then. In adults, this moves rather slowly, years oftentimes.
So would you recommend for those of us who are not wondering, or maybe our kids were exposed and we didn't get, so if we become, would you recommend that we get our TB test if we have symptoms that might
No, I think if you're significantly sick with cough and fever, and you were exposed to this individual, then I think you would seek medical attention. And my recommendation would be a chest. If you're sick and it's not going away, it's not a cold, then I think it would be a chest X-ray, rather than just repeating the skin test over and over.
We haven't taken one from over here, and there was one. Yes.
I don't need a mic. I'm fine. I was wondering. I got the second follow-up email. I have 2 children, and when will I discover which one or both are in the high-risk group?
We have spent today calling. We went through the entire list of every family with siblings. There are a handful of folks we weren't able to reach, so we can tell you that before you leave tonight.
Yes, up in the back.
So will we have a schedule of when our child is going to be tested, or do we just show up 8 o'clock Monday morning and wait? And yeah, so, and when it'll be read as well? Is there going to be some kind of schedule?
Sarah, do we know that yet? No.
No, we haven't.
We don't know that yet. I imagine there will be some sort of schedule as far as classrooms, kids versus adults, to the testing day and the reading day, but we haven't sorted that out yet. We can get that information to the school as soon as we have it, so that for parents who want to be there, we can make that available as soon as we can sort it out, but we're not that far along yet in planning those days, unfortunately.
And also, does somebody who's been exposed at a higher risk, if they have a sibling, does that mean that that sibling is exposed at a higher risk as well?
No.
No?
Do you want to?
Again, people who've been exposed can't transmit it.
Okay.
So that's, and I'm glad you brought that up, because we have to, it's a little bit complicated.
Can you say that again, please?
Sorry. People who have simply been exposed, their skin test is positive, they go for the chest x-ray, the chest x-ray is clear, they can't infect anybody. They're not.
Can or cannot?
Cannot. So someone who's really been exposed, who has a positive skin test and their chest x-ray is clear and they're asymptomatic, they're not going to infect anybody at home or in school or anywhere else. That's, again, the thrust for them is to get treatment so that down the road, 5, 10, 15 years from now, they don't develop tuberculosis.
And then they might be able to make someone else sick if they developed tuberculosis themselves. That just confuses it. Yes, same lady.
I'm just having a hard time understanding how someone could have worked up until Friday and then landed in the position where you all know about it. Were they not coughing all this time?
One of the things about tuberculosis is, and I'll try to avoid my diatribe here, but one of the things about TB is it's not very contagious. So in order for it to propagate itself in the community, it has to keep you out and about so that there's a chance that you might infect someone. Otherwise, TB would go away. So it has evolved not to make people terribly sick. So it's not unusual for us to find that people continue to work, people continue to go to school, people continue to congregate with family, even though they have active tuberculosis. We've found people, anecdotally, someone slips on the ice, gets an x-ray of their rib, feel totally fine. Oh, by the way, they have tuberculosis. You can be minimally symptomatic at times. That's why everybody with a positive skin test has to get a chest x-ray, even if they're feeling well. So it's not, I totally understand your question, but I can just tell you that it's not unusual for people who are sick with tuberculosis to continue working or to continue going to school if they're a student, because they may not be terribly symptomatic.
That kind of suggests to me that it would be generally a good idea for all public school workers to have a TB test every year, just to make sure that this isn't.
Yeah, it's not recommended. The yield would be essentially 0. So it's a good question, but I don't want to get sidetracked on that because that's more of a policy.
Yes, ma'am.
We keep talking about things in generalities in terms of low risk, medium risk, higher risk. Can you quantify for us? What are we talking about here? 1 in a million? 1 in 100? What can you quantify as risk for us?
1 in a million or 1 in 100 of what?
Chance that X number of children are going to have this.
I think I understand. Every case is different. We've certainly learned that, and every individual with tuberculosis ends up behaving differently in terms of who they infect and don't infect. So we've had cases of tuberculosis, lots, who haven't infected essentially anybody.
Even at home, in their household?
Even household. Spouses don't even turn out to be positive. Other people seem to be, unfortunately, more efficient at infecting people. So we're just going to have to wait and see what comes out of the skin tests we do in this round. I can't tell you that out of all the people tested at this school that 1 out of 100 on average will be infected, or 1 out of 1,000. We just don't know. I mean, there's really no way to know that. And it'll really depend on the ventilation characteristics and the nature of this person's contact with others. I mean, there's just no way to to say for sure.
And just a quick follow-up with when you have tuberculosis, it sounded like you were saying if you were treated, you are cured of tuberculosis, or do you have it in your system forever?
Yeah, the medicine is the way to think about the medicine, it's an antibiotic. It kills the bacteria. It just happens to be their TB antibiotic, so it's not amoxicillin. So if you take it on a preventive basis because your skin test is positive, it will kill whatever you were exposed to, so it can't come back to make you ill again. Now, it can't say 5 years from now you might travel somewhere in the world and get exposed again, but for this exposure, it would take care of it. And similarly, if you're sick with tuberculosis, then you get curative treatment. And then you're done with that for the rest of your life. And there, that would be documented through testing, follow-up chest x-rays. So people are cured. So it's not something you would carry the rest of your life.
So the only way you can get it is by coughing on someone?
The only way you can get it is inhaling the air that someone has coughed into. So the only person who can spread it is someone with active disease in the lung. And when they cough, they liberate these bacteria into the air. And then in a closed, less well-ventilated area, unlike this room, someone would have to breathe in enough of those bacteria to make it all the way out into their lung and cause an infection. So it's purely airborne. One thing that came up earlier today we should mention, because my question might come up, is surfaces, tabletops, chairs, the environment, nothing like that can transmit tuberculosis. So currently at the school, none of the inanimate objects or the environment itself is a concern in terms of transmission. You can only get it from a person, and you can only get it from a person who's sick with it. So for the people who have a positive skin test next week, don't be hysterical. You're just going to get an x-ray to make sure there's nothing on the x-ray, and then you'll be offered preventive medicine, which is a good thing, to make sure that you don't ever get sick with this.
Yes, ma'am.
This might have to be a follow-up question, but I'm curious about the site of the skin test and curious about children's natural tendency to compare. And I think it might be a sort of strange 3 days while everybody's watching their bumps grow. And I really would like to hear about how that's going to be handled. Hopefully not grow, but it's an interesting situation with so many children, especially if they can see each other's bumps.
Yes, I think you're right. And I think it's what did you say?
It's going to be a strange 3 days.
Yes, it will be a little unusual. Yes, so it's right around here on the forearm and just under the skin, intradermal. So like you explained, in between the first and the second layers.
And a positive will not be a glaring abnormality. Like a kid, I don't think would probably even notice it.
That's my question.
Right, it's going to, a positive would be 5 millimeters or more of a bump. So, a vague little bump there on the form, that's going to be a positive. So what you hope is when they return to have it read, there's nothing you can feel on the skin. That's a negative. And most people, I think, don't even realize that they're positive. They assume it's negative. They don't realize it's positive until they actually get it read. So it's not going to be a glaring abnormality that I think kids will be talking about. But
My experience, and I've been doing this for almost 9 years, I've done a lot of children. The bump, I call it looks like a mosquito bite, a bad mosquito bite. And it's puffed up for a little while and then sort of absorbs and goes away. So most kids either have maybe a little redness where the injection was put. Sometimes it looks a little bruised. Sometimes there's a little bleeding, so there's a little scab, but pretty much almost disappears. So there's really almost nothing to compare. Yeah, I would say in a few hours it's absorbed and it doesn't stay a bump for the 3 days. It gets absorbed.
And the reaction we're looking for has to develop, and it takes a couple days to develop. So you really have to wait 2 or 3 days to read it. So after a day or so, there shouldn't be anything there, but the question will be at 2 to 3 days, is there anything there that we can feel? And if we can feel something, then we'll try to measure it as accurately as possible.
Yes.
I had a few questions, not necessarily related, but I'll just go through. The first is,
And when you were looking at the high-risk groups, did you also include people that might volunteer at the school? Was
Yes.
it just the staff?
Yes.
So it included a larger subset of people?
Yes, yes. Mm-hmm.
Okay. And the second is for the skin test. Can you explain why you chose the skin test and not to do the blood test? There's a blood test available.
Yeah, the IGRA or the quantiferon tests, right? So both tests are equally good tools, especially in you know a school age group of school age children in this setting. And but the blood test is an option, but we'll be doing the skin test here because it's technically easier for us to carry out on children. We can do it, you know, quickly here and read the results. But certainly, if you decide you prefer to have the blood test done by your provider, that is an option.
And then lastly, if my child has recently had a dose of antibiotics, would that interfere with the test?
No, that wouldn't interfere, but I'm really glad you asked that question because one of the things that we will screen for is having received a live virus vaccine recently. This is not harmful in any way, but the timing of the live virus vaccine, for example, measles, mumps, rubella, varicella vaccine, those vaccines are live virus vaccines, and they count on the immune system, you know, to do some work after the vaccine is given. So it's really best not to do the TB skin test for a month or 6 weeks after the vaccine. Not because there's any harm, but because the skin test might not react the way we want it to. You can give both the vaccine and the test on the same day in the clinic, for example, but we'll ask that question just to make sure the timing is the best.
Okay. Sir, you had a question for a while.
To answer Eric's question, fever, if the fever is persistent and doesn't go down, that's when you want to call your healthcare provider. The testing efficacy for the actual skin test, the PPD test, is not equally as definitive, mainly because the skin test is a subjective test. So you have somebody who reads it, although the efficacy of who reads it is apparently, if they've read a lot, it's usually better. The other is an actual blood test that they're measuring the antibodies to the actual TB exposure. So it's your body's immune system. So you actually get a quantified result. They're not, you stated they're equally as good. One is more refined than the other. You can also have false positives. The question for the health department is if there's a false positive, or if somebody is positive, do you suggest going on 9 months of therapy? Keep in mind the medications are not necessarily inert. Or would you suggest a follow-up to actually do a quantiferon test to make sure that the positive that you got from the skin test is accurate and appropriate for 9 months of therapy? This is, I know you guys are you're walking the line between, you're walking the line between inciting people and trying to get enough information out, but you're on the wrong, you're a little on the wrong side. So it's a well-educated group. There's a lot of healthcare providers. Most people here have already contacted a healthcare provider that's not even their own. So you need to give us all the answers and not be too worried about us screaming around town, lighting fires on buildings. So please be accurate and tell people what their options are, rather than saying things are equal and being vague. And so the other question is, so susceptibilities. Will you be conveying susceptibilities for the sputum? So if there's any resistance to it,
We can, when the results come back, we can reassure you that it's a drug-sensitive strain.
okay. And origin of the TB, do we know? The country of origin, location, specific? We don't know where they picked it up, recent travel?
Well, we know.
It makes a difference because in some countries, the amount of resistance is different.
Resistance testing will answer the resistance thing irrespective of the individual. So we'll have resistance testing.
What does that mean? Can you explain that? I'm sorry.
So the person's strain of TB will be tested in the laboratory to determine whether it's resistant to any drugs, and that will answer the question regardless of where the person's from or where they contracted it.
I have a question in regard to the blood test. I'm just wondering, I do have a child who has had multiple vaccinations in December. Are you going to offer the blood test? Because I would much rather just do that Monday.
No, we are not going to be doing the blood test on Monday. But again, if that's something that you'd like to pursue, we'd be more than glad to speak with your provider about it or let you know how that would be available.
I'm sure you guys have looked at this really carefully. Like, are you able to assess the risk, you know, in terms of some statistical numbers about how many kids that may be affected? I'm wondering if there's been any talk about the risk of potentially infected kids infecting other kids or siblings at home, and how closely did the infected person work with our children that are not? CDC, I know that he said that the only way to contract or have this disease spread is through coughing, but the CDC actually says coughing, singing, speaking, and sneezing, which to me, if you're in close proximity to someone and you sneeze, or you're speaking and you're someone that speaks with a speedy sort of voice, like to me that seems like the potential is maybe higher than just someone coughing and not coughing into their elbow. Because I guess my concern is that, you know, a potentially infected child, my child, I guess, is comes home to a house with other siblings in it, is going to an art class after school, is going to a sports practice, is in the locker room, and singing classmates, everything.
Again, the only way your kid could infect somebody is if they have active pulmonary disease, which would be demonstrated on chest x-ray following a positive skin test.
Okay, so if they were exposed to the person who has the TB, and we find out next week that they have active pulmonary disease, and they're actually sitting next to other people, are they not at risk to expose them?
If they have active pulmonary disease, then the other people are at risk, sure.
So I guess I'm curious as to why the children that have been why we're still having to schools doing it to other kids when we don't have the answers to those questions yet. It seems to me that we're putting a lot more kids at risk within our own system before we know all our answers. So maybe I'm missing something. I'm just curious if I'm missing something, or maybe I should be concerned about that.
I had the same question. I'm just wondering if you considered making the recommendation to the administration to cancel school until we have at least those preliminary results on Thursday, because
So no.
Like you're saying that there's more possibility that if there's infected children.
There's absolutely no indication to cancel school or curtail any activities or to keep kids who have been in school and potentially exposed to this individual away from their siblings or any of that. Because the only way that they could be, they've potentially been exposed, and yes, it may turn out that in fact they have recently been infected with TB because of their exposure to this individual. But unless they're actively sick with TB, they're not putting anyone around them at risk.
But we won't know that for a while, and they could be presenting with symptoms that might appear like a cold, and obviously if we have fevers, we don't send our kids to school, but if they have, you know, a mild cough, so they might be in school. So we are increasing our risk until we have some preliminary results, right?
Go ahead.
Right. So, yes, I see what you're saying, And I mean, not to in any way try and minimize what you're saying. It is a concern for sure when you, as a parent, know that your child might have been exposed to TB, and you're concerned that your child or another child in the school is now maybe having some symptoms, is still going to school. Is that right?
Correct.
Right. So there's contact investigations that have been done, including school contact investigations. I don't mean, just in Vermont, but in general, this is not easily transmitted in school. Do I guarantee that there hasn't been transmission? No, I can't. But it is not generally something that is well transmitted in the school setting, and it's not considered to be worth canceling activities or closing school for for exposure to a case of active TB. But that said, it still is really important if your child or family member is ill and not getting better, like we said earlier, with respiratory symptoms or with any illness that has a fever. Yes, you should pay attention to that and have that person evaluated by a medical provider.
Although this person showed up till Friday.
Right. Okay.
Yeah, that's true.
Standing at the back.
Right.
Yes.
So my understanding that TB disease does not always present with cough. Does it always present with fever?
Not always. I would say most of the time there are fevers. Yes, not always, but a lot of the time.
I think the emphasis on the lung is that, number one, that's the most common site of disease, and number two, that's the only kind that can be spread. So there are two, right? So there are two kind of ways to look at it. One is evaluating a sick individual. And I think for a sick individual who's having persistent fevers and losing weight, someone's going to have an open mind about whether they could have tuberculosis anywhere else in their body. But from a public health transmission standpoint, we just have to make sure there's nobody here who has active disease in the lung. So so not everybody has a fever, most do. Not everybody has a cough, most do. As with all things in medicine, nothing's 100%. Yep, because you have to put bugs up into the air. And the only way, you can do opera singing in someone's face and you can infect them that way. I mean, you have to get bacteria into the air that someone else can breathe. So if you have TB and a lymph node in your neck, you're sick with TB and you've got it in your lymph node, you need to be treated. But from a public health standpoint, your lymph node can't infect anybody.
So that person who has it in the lymph node, even if they're coughing and...
If it's not in their lung. It's not in their lung. Right. And so the cough is, in terms of transmission, cough is really key. Some people, even with pulmonary tuberculosis, don't cough much. And we just don't hear them coughing, and they don't, big surprise, don't tend to infect anybody. Other people have really forceful cough with a lot of sputum and never cover their mouth when they cough. They're going to be more at risk for infecting other people. Everybody, that's what I was saying, everybody behaves differently, and we won't know until we start getting the tests back. I wouldn't be surprised if some people here are found to be exposed. Well, let's face it, that's why we're here, that's why we're having this meeting. And that's why we need to treat those people so they don't ever get sick.
So it's safe to say that our kids, whoever this individual is, have been exposed potentially every day for the past 5 months to this person's active TB. Is that safe to say? And if that's safe to say, I would like to make a plea to this person via Audrey and Greg for the common good and for the sanity of parents. I mean, any chance this person's going to step forward so that we can say, oh, so-and-so, okay, my kid doesn't have exposure to this person. I mean, this person's privacy apparently is more important than the public good in this case.
So, like I said, we've talked to the school, talked a lot about what this person's role was and who they interacted with, and we feel like we've really identified, you know, a third or so of the entire school population who interacted with this individual, and were, I would say regularly, maybe not every day, each of them.
Can you tell us, other than the adults, is there a specific age group that's been affected? You see what we're trying to do?
Yes, I do.
So my question goes right along with this is, I don't care what the person's name is, I don't care where they live or what they do. All I want to know is what is their position in the school? Were they a recess monitor? Were they a lunch aide?
Why does it matter?
Because that will let me gauge as a parent whether or not I should be more aggressive with watching. You know what I mean? It lets me make a better decision about my child. And I appreciate the fact that you're making decisions and you're in the process of making decisions. But, you know, this is our these are our children.
I understand that. But, and I would ask you to understand that we know these are your precious kids, and this is what we do. This is our job, and this is what we've done over and over again, is these contact investigations, and we know what it takes to be exposed to TB, and we know what type of interaction it takes, and you don't necessarily. And so it is our job to make these decisions.
I appreciate that.
And it's your
like
job.
Condescending, because there are lots of us in the medical field. I myself have been an EMT.
Yep.
Not that that's perfect or compares to doctors or MDs or whatever you want to say. But the point is, we just want to know the position, and then we can gauge whether or not we think our child, where the risk is.
Yeah, and unfortunately, we're just not going to release that information. Yes, sir.
How many contact investigations have you performed in a public school setting in the state? One question. Second question, do you know when this individual was potentially infected and or how long this individual has been susceptible to transmit?
So I don't think we have any idea to know when the individual was potentially infected. Probably could have been decades ago. We think the individual could have been infectious since the beginning of the school year. Was that your final
last
question?
Year or?
No, we don't think so. Based on when the symptoms started, again.
Which were?
I'm not going to talk about an individual's symptoms. And how many school investigations have we done? One very similar to this in the last few years. Others in not schools, but other settings like schools. And other workplace settings.
Congregate settings of different types.
So if you can't talk to specific symptoms, can you at least give us when you feel the symptoms started?
When did school start?
And they just started that first day?
End of August.
So, you know, that's what we're assuming for the school year, that the person
They started on the first day of school?
Potentially based on when they report symptoms, and it's possible throughout this semester or whatever you all call it. Could be.
Right.
Yeah. Yes.
When you talk about symptoms, can the TB kind of ebb and flow in terms of your overt symptoms?
Yeah,
so kind of have a cough.
I guess like anything, you know, it doesn't tend to really get better much on its own. So someone be persistently. So that's, you know, again, I think there have been a lot of questions about, well, what if one of us or one of our children gets sick? I mean, it's not going to be the transient cough and sniffle and fever that goes away in a day or two. One of the hallmarks of TB is it's really a chronic infection, as evidenced in this case, and so people are not going to get better. So I think the thing among,
but I mean,
for all
you know,
of you,
like for instance, you could have a very, you know, like the fever and lots of coughing, and then a cough that kind of just hangs on for a long time and never goes away, and maybe it gets worse again. Would it do that? Or?
I suppose it's going to be pretty. You're not going, without treatment, you're not going to likely get better on your own. So I wouldn't think that the symptoms would ebb and flow that much. It'd be pretty constant.
Pretty constant. Okay, thanks.
Yes.
Yes.
Are asthmatic children at higher risk?
immunocompromised people.
Yes, sir.
Obviously, there's been a lot of buzz about this past 24 hours or so. I think there are going to be a lot of nervous children. Is the school planning any group information sessions, information appropriate, age appropriate sessions for the kids, or individual counseling options?
So we're working with the Department of Health to get some age appropriate talking points, and with our school counselors and classroom teachers working in collaboration, we'll be giving appropriate information to kiddos. And obviously teachers will be watching children carefully for those who they think might need a little extra attention from somebody else at the school.
Can I ask about the timing of when that information is going to be given? My daughter came home today and told me that all the kids in school are getting shots next week, and she was told by the school official. So I thought maybe we could tell them, and then the school would talk with them further, but she already knew. So I don't know how. I was just wondering how that's happening.
Some of that's tricky because you can't necessarily control what a student picks up in the classroom, and you don't want to ignore questions. You want to answer them in a developmentally appropriate way. So I know that happens today in some classrooms. Teachers handled it really beautifully without having a lot of prepared talking points ready. So when those questions come up, we want to deal with them. But we don't know exactly when tomorrow.
So tomorrow, though. So we should talk to them tonight.
Yes.
Okay.
Yes, sir.
Yeah, you guys touched a little bit on some patient-specific factors that would bear on either the efficacy of the test or potentially their risk category. They may have other conditions. How is that information going to be collected in time for the test on Monday? So in other words, did they get a live vaccine? Maybe they're on an immunosuppressant, or maybe whatever it is. There's probably some patient data you're going to need to make an accurate judgment.
Right. So that will be those questions will be on the screening form that will, have your signature on it, and that will be one of the questions.
We've also gotten some of that information already from the school nurse.
School nurse. So.
And are there other individuals that may be at higher risk for complications if they had TB that would move them into that category, even though their contact assessment maybe wouldn't put them in that category?
Right. Yes. So a child with certain risk factors or immunocompromised, chronic illness, for example, we would, tend to include in the highest risk group sooner rather than later. So yes, that's one of the things we are taking into consideration.
Okay, so you had access to some of that information to make your high risk grouping?
If they're on an immunosuppressant, like prednisone or anything along that line, Crohn's disease, some TNF-alpha inhibitors, that sort of thing, then if their immune system is suppressed on purpose from medication, they will be more susceptible to an infection.
One would be, I just want to understand, you said there would be the first initial testing, and then the second one, is the second one only if they're positive, or did you say it doesn't show up? Sometimes
Yeah, so let's try to go through that, because I know it's really complicated and confusing. It takes 8, 10, 12 weeks to turn a test positive after you've been exposed. So the baseline on Monday will reflect an exposure that could have occurred 8 to 10 weeks ago, anytime up until then. From the time the child is born up until 8 to 10 weeks ago, that will be reflected on Monday's test. But because Monday's test will not therefore reflect the last 8 or 10 weeks during which exposure could have continued to occur, it needs to be repeated 8, 10 weeks after the last exposure. The only reason not to repeat it would be if the first round's positive. If the first round's positive, you don't need another one, right? If the first round's positive, no more TB tests. You go for a chest x-ray. But if assuming the first one's negative, then you need a second repeat. Had the last, had this person stopped coming here 3 months ago, we wouldn't need the second one because we'd be out of that 10 or 12-week window already.
And if somebody does sneeze in zero, like you said, you said it's not services or
Right.
like, how long does it live that way? Like, how long does it actively?
It can, you know, in a very poorly ventilated room, someone who's actively coughing, it can stay suspended on air currents and can infect, you know, once that person's gone out of that room, those things settle out over the next hour or two, and then there's no risk anymore. It really depends on the size of the room and the ventilation characteristics. For example, you can't transmit TB out of doors because whatever you cough gets diluted in the entire atmosphere, right? And in a huge room with a huge ceiling and ceiling fans like this, no one's going to get infected. It's usually prolonged, face-to-face, indoor contact in a smaller room. That generally, now we can't predict what's going to happen in this, we don't know what's going to happen in this case, but generally those are the circumstances under which transmission occurs. In someone with a forceful cough who doesn't cover their mouth. You can imagine that if all you have to do, I mean, if you cover your mouth every time you cough, whatever bugs you cough embed on the tissue, and you're probably not going to infect anybody. Every patient is different. And like very small children, even if they have active TB, don't tend to infect anybody because they don't tend to have forceful enough coughs to put a lot of bugs up into the air. Transmission usually occurs from adults. And when, yeah.
Sorry.
No, you're good.
So my last question, this is just kind of like a picture, like for my family right now, like as a parent. So I have two children here also, and one I believe is in the age group that's kind of in the higher risk, but the older one is not. But it happens to be that my older one right now is pretty sick. And so I'm questioning, do I need to worry more? Like he actually did have a fever for over a week, and he did get diagnosed with flu and pneumonia, and now today he's put on a nebulizer. So should I be concerned?
I think if you have a sick kid, you would go over with the health department who that child is and whether that child had exposure to this individual or not. And again, the exposures we're not, I really want to try to help you all with this. We're not talking about passing someone in the hallway or saying hello to them. That's not how you get to break. Again, I've never been exposed, and I've dealt with hundreds of people. So it's usually the people who end up being infected are the people who have prolonged face-to-face contact, and hopefully that's something that the contact investigation would be able to provide. So I think if someone's sick, the question would be, did that person have exposure to this individual?
Well, that older son was not in this first list of being tested.
So then it should not be tuberculosis. And again, it's not going to be secondary transmission unless there's another case.
And you said you'd offer a second clinic a week or two later for those maybe cases where people want to get tested that weren't that frequent.
Yes, we will offer another clinic a week or two from now, once this high priority group is done, for people not in the high priority group. But first we need to see what the results are, because if we need to expand and do another priority group, we'll do that as a priority. Yes?
I think the hard part is, I hear what you're saying about prolonged exposure, and if you read on the internet, it even tells you you're supposed to be telling your doctor, they're asking you those questions, but we're not being told who that person is, which I completely understand. I get the confidentiality, but I don't understand why we can't know what grade or what classroom to get a better understanding of how long that exposure is, because I don't know. I mean, you're telling us one thing, but we don't have the information to make a decision. I don't know. You don't have to tell the person, but within a month, we're going to know what teacher or whoever is not here anyway. So why can't you have more information now about the grade?
Or the room. You said yourself, if it's like this, it's really big with good ventilation, or outside, obviously makes a huge difference if it's one of the smallest classrooms in the school.
We're hearing you. We're hearing you.
Legally can't say anything. That's the reason why
Yes, they
they're.
can.
And I respect that. I totally respect that.
We're hearing you. We're not going to give you obviously the name, but we're also not going to give you the grade or any other identifying information. This may help. Next week, next Thursday, we'll know that 140 or so of what we've identified as the highest risk people, so about a third of the school will have been tested, and we'll know how many of them have acquired TB, potentially from this individual. And we'll make a determination from there. You know, if it's 1 or 2, then probably, you know, we might not think we need to test the whole rest of the school. If it's a bunch, we might say, yeah, we better test the whole rest of the school just to make sure we capture everybody. And so, can you say, I know you're anxious, I know these are your children, but can you say, let's wait 1 more week and we can go from there, based on what we find with this first round of testing, who we really think are the highest priority for testing, and they should really tell us a lot about how much transmission there might have been from this individual, because as Kemper has said, you know, every TB case is different. Some people spread it to lots of people around them, some people don't. And so results next week will tell us a lot about how much this individual spread it to people around them. Does that help at all? A little bit? Thank you, though. Up there.
My question is about risk if your child has a history of immunosuppressant. He's not currently immunosuppressed, but he was for several years, many years ago.
If the immunosuppression is removed and the child no longer is immunosuppressed, then I wouldn't think they're at any increased risk. Immunosuppression probably doesn't affect their original exposure much, but it affects, if you're exposed, the likelihood that you'll progress to active disease or not. For example, the highest risk thing is to be HIV positive. And I said, adults, healthy adults, their lifetime risk at most is probably 10%. Someone who's HIV positive, it might be 10% per year. If you have an organ transplant and your immune system is shut off by medicine so you don't reject your organ, you're going to be at higher risk of tuberculosis. It's not any kind of immunosuppression. It's very specific types of immunosuppression that target the arm of the immune system that fights TB, like HIV does. So if a child had an illness years ago and were immunosuppressed then, and they've been to recovery and are no longer immunosuppressed, we would think that they would be at significantly increased risk. Yeah.
So if a child tests positive in this first round,
right,
are you then going to assess who they had contact with and
again,
test their classroom?
Only if their X-ray is positive. So again, exposed people are not at risk to transmit. So a person who's positive on the first round next week will get a chest X-ray. If their chest X-ray is clean, they don't have active pulmonary disease, they can't infect anyone. So they'll just be moved into the preventive therapy group.
But if they
have to have an X-ray, you're
right.
But
if their chest X-ray shows that they have it, will you then expand the testing to their classroom?
Then we'd have to think about who they were exposed to. And so there may be a second look. That's right. So everybody, as part of this investigation, including the index person, anybody who's found to have active pulmonary disease, their contacts will have to be tested. And their contacts may be different than the original contacts. That's right.
So it makes sense to me to just kind of put everything on wait until you get this first round of tests back before it potentially spreads more and more.
I'm not sure that's what we're doing. I'm not sure I understand.
Stopping school is what you're talking about.
So you do it in public health, they talk about sort of concentric circles. The first circle is the group with the highest exposure that you're most worried about. And you learn from that how many people in this immediate group got infected. If nobody in the immediate group got infected, it's less likely that the peripheral people got infected. If we find a bunch of infections in the immediate group, we may have to expand the circle and include in the next round of testing people who had less contact. Maybe this person turns out to be transmitting it pretty efficiently. So we're going to learn from this as we go and expand the circles. We will probably find people who've been exposed, and we need to prepare ourselves for that.
Yeah. What's just sort of in the general population? What's the incidence of like a false positive? So when you say you're going to find people
false positive.
Yeah. Are you going to?
Yeah. For the skin test, the biggest cause of a false positive is having had the vaccine, and we don't use the vaccine in the U.S. So for those of us who were born in other countries who got the vaccine, that could be an issue, especially if there's a child who's born outside the U.S., because other countries tend to give it at birth. But the biggest false positive problem with the skin test is people who had the vaccine, and we don't use them. American-born did not get the vaccine across the board. the big advantage of the blood test, really, that we're not doing is that it doesn't show positive from the vaccine. But since we didn't get the vaccine, we don't feel so strongly about that. And the blood test has a lot of false positives in it. So the skin test has nearly 100 years of experience behind it. Yeah.
So if you do this first round of testing,
right,
regardless of what the results are, did you, I think Steve had said earlier that there was going to be a second, maybe optional for people who wanted to be tested. Could you just clarify that? It might be a repeat. Sorry.
Right, yes. So we'll, needless to say, do the first round of testing next week, and then also repeat a round of testing for the highest risk individuals who are negative in 8 to 10, 12 weeks later. And yes, we're planning to be available for testing if you'd like to have it done in a week or two. I don't have the date right now because it depends on, you know, we have a lot of things to accomplish right now, and we are going to plan to offer that for others who are interested, yes.
So that would be a week or two from
yes,
next week kind of thing,
yeah,
or a week or two from this?
I'm not, right now, I'm not sure exactly how soon after, but we'll do it as soon as we can, you know, taking everything into consideration, yes. And do, I mean, you know, do give us a call if you feel like you need to ask some individual questions at the health department. You know, we prefer that you call during normal business hours. You know, that's when we have the most people available to talk with you. And we're also, like I said, we're happy to talk with your provider if there are questions or concerns where we can work with you and your provider.
Yep.
So this might be a question that I'm not sure Audrey or Greg might be better suited to answer, but there was a 5th, 6th grade concert tonight that was canceled. And so my son who's in 5th grade came home very disappointed and upset because the concert was canceled, but yet we're still asking them to go to school tomorrow. So we're really sending them a mixed message, and I didn't really know what to tell them, to be quite honest, because I agree it's a mixed message. We're canceling the concert on one hand, but yet we're saying it's safe to go to school. So I'm not quite sure how to respond, so any suggestions would be helpful.
No, I don't, canceling the concert wasn't related to TV exposure.
I believe it was.
We chose to cancel the concert because parents had contacted Greg and I and said that they weren't going to have their children stay here. We were concerned that there weren't going to be enough students to have a concert. Because of parents' concern, we made a decision to cancel the afternoon concert and the evening concert, even though we said that the Department of Health had said that all extracurricular activities and concert activities could continue. It was a response to parents' concerns, saying they weren't going to either participate or have their students participate. And that was our decision.
Was that based on students that did not come to school today, or based on just emails and phone calls that you got?
Emails and phone calls that we received all morning, that they were going to pull their kids before the concert.
But yet those students came to school, or no?
We had a higher rate of children who did not come to school today as well.
Okay, so so any suggestions for how to, you know, my son basically came home and said, I don't feel safe going to school tomorrow. This is a significant concern that they canceled the concert. And I did try to explain that, I guess, that, you know, as the
and we tried to emphasize that in our email to parents as well as to the students, that we were told that it was safe for students to be here. However, your parents were concerned about having us all together in a space to have this concert for both the afternoon and in the evening.
So I guess I understand. I think it's a tricky message for us.
Very hard.
Students, so I guess we just need to be prepared to, you know, help have them feel safe and comfortable, or make a decision not to have them be in school.
I actually just told my daughter it was because we couldn't, and I wasn't one of the parents that called, but we couldn't be in two places at once. Parents wanted to come to this meeting, and the concert was going on at the same time, so how would they have gone, you know? So that might be something, I don't know if it was true, but
right.
That's what I told her.
Yeah, I don't
know how to explain it.
any negative consequence to having this skin test?
No.
It's very, very good question, very safe test. We give it to pregnant women if we need to. It's very safe. It's an inactivated protein.
It's not a vaccine, right?
Right.
It's nothing live. It's protein from the TB bug. So you put it into the skin. If you've never been exposed and your immune system therefore doesn't recognize TB, doesn't do anything, nothing happens, there's no bump. A negative is no bump at 48 to 72 hours. If you breathe in TB and your immune system has been exposed to it and recognizes it, then when we put protein from TB into the skin, your immune system goes crazy and thinks, oh, there's more TB, and you make a bump. So it's just protein from the bug, so it's incapable of hurting the bug.
So later on in life,
Yeah.
somebody who's had a test
Yeah.
now in this circumstance, if they ever have to be tested again,
Yeah. If you're negative, you can always be, I've been retested 1,000 times. If you're negative, you can always be retested. If you're positive, once you're positive, to some degree, you might always be positive because it's not the bug itself, it's your body's reaction to the bug, and your body remembers it. So once positive, always positive. So if anybody tests positive on the first round, they don't need any more TB testing the rest of their life. If anyone tests positive on the second round, no more TB testing. For people who turn negative, they can always get tested again in the future. Because they're negative, their baseline's negative, you want to see if they turn positive. Once positive, pretty much always positive, there's no real reason to repeat it.
we really want to put our minds at ease,
Yeah.
we test.
You test, and just remember the caveat that either the blood test or the skin test, they really are interchangeable, only demonstrate what's happened up until about 2 months ago. So it would reflect, so just keep that in mind when if you want to do testing on your own, which you certainly have the right to do. There's no harm in testing someone. You know, it's a little bit of a sting, it's very inexpensive, it can't hurt anybody. But it would only reflect, because it's not the bug, it's your body's reaction to it, it only reflects up to about 2 months ago. That's why
I know.
Yeah.
So positive result, clear chest x-ray,
Right.
means you have a choice to go on antibiotics? Or
Right,
you should?
technically speaking, someone who's been exposed and has a positive test but a negative chest x-ray isn't a threat to anyone because their chest x-ray is clear. You can only transmit it if you're sick in the lung.
But you could
So that
get
person
that
doesn't.
x-ray months down the road or years down.
You can always check if you don't get treatment, you can always get sick.
Right,
You
is
get sick
treatment
from-
optional? Or is
So
it?
treatment for exposure, treatment is ultimately optional because you're not a threat to anyone else. If you're sick with TB, then you need to be, from a public health standpoint, you need to be treated because you're a threat to others.
Last question for me. Is CCS ground zero in the state for what's going on here? And the other part of it is, you understand the fear factor around here. This is kind of like stuff you guys go through all the time. This is all like really scary about, terrifying. I know you appreciate it.
Yeah.
Can you assure us that this whole thing is being done out of an abundance of caution? With the emphasis on the word abundance? Or is this something that we should have more realistic level of concern about? Kind of a long question.
Sure is. I want to know what's going on.
We have no interest in doing an incomplete investigation. So you know, that's the job of the Vermont Department of Health, is to protect the health of the public. Right? There's no, you know, our job is to find out who's been exposed and make sure there's nobody else with active disease to the best of our ability. So we're here to support this. That's why we're here.
And this is ground zero right now. That's to say there are other cases in Vermont that are cropping up, or nationwide.
Vermont has other cases of tuberculosis now, again, but unrelated to this one.
Related to
Again, there are about 9,500 to 10,000 cases of active TB disease in the United States per year, a few of which occur in Vermont.
In the school population in Vermont.
Not currently in the school population, not currently. There are a couple other people in Vermont being treated unrelated to this situation.
On the wall.
Yeah, I might have missed this earlier, but you hear a lot of anxiety out here. I might have missed earlier the rationale for not casting a wider net on testing. If it's safe and it's cheap, why wouldn't you just eliminate anxiety and get results better for you, better for us? Test the population at once, speed up the clock, everybody kind of gets a better understanding of what is or isn't risk.
Right, so it's a really good question, and it's not the most efficient and the best way to do an organized contact investigation. We can do a much quicker job if we go in a step-by-step organized plan to pick the highest risk to test first and focus our time and energy on those results. And that's not to say that you can't, if you want to go ahead and get tested sooner rather than later, that's really okay. But we really want to use our resources to do it in a step-by-step method. So again, no problem if you feel better going ahead to pursue a test. If you'd rather not wait until the near future clinic, not next week, but a couple weeks later. If you just really would like to go ahead, then there's no harm in that, but it wouldn't be the way we would organize it.
Is it more just a logistics thing?
It's partly logistics, but it also enables us to pay the most attention to the highest risk people first.
And also, as you found from tonight, just going through testing creates some stress. There's really no reason to test people and put people through testing who don't have any reasonable risk of having been exposed. Because one thing I've learned over the years is just putting people through testing, and we've raised that issue to the kids. The whole process is stressful. And so for people who really haven't been exposed, to the best we can tell, then now, again, if this person turns out to be someone who's infected a bunch of people, then we'll probably do subsequent rounds. This is not something like the flu where you get exposed and 3 days later you're sick as sick and back. It's not. TB is sort of untreated, is sort of a lifetime thing. I mean, people may not get sick for 50 years. This is a chronic infection. We have a little bit of time. We'd rather take a day or two here or there and do it correctly. The logistics of doing 140 skin tests is not minor, but it's better to do it correctly, collect accurate and complete data, and know exactly what we're doing, then suddenly test everybody in the whole place whether we had any exposure to this person. So just bear with us. This is the standard way these things are done. I understand design.
So let's say you get a positive and then you're supposed to follow the do you know how insurance companies work with that as far as how that is covered and then under coverage weeks for 9 months, like what the coverage is or something like that with
I don't know how insurance companies do that, but I do know that from the Vermont Health Department can be the payer of last resort. So if insurance does not cover some or part of it, the health department can pay those bills.
We would hope that finances would never be a barrier due to the diagnosis and treatment. If there's insurance that can be billed that we cover it, that's great. If not, we'll figure out something with more help. But money should not be a barrier for anyone to either get diagnosed or treated.
And the health department does pay those bills for people all the time.
Will you need health insurance?
Doesn't cover those types of things.
For the kids to get tested. Will you need health insurance? No?
No.
Okay.
No. And so the question was, do you need health insurance to get tested? No, we're not collecting insurance information at the clinic on Monday. There's no cost at all. No insurance information collected, nothing. Yes.
I want to latch onto the ground zero again in the concentric circles. This person's in our community. Are there other concentric circles there that you're examining?
Yes.
In our community in Charlotte? Church? Gym?
I don't think so.
I don't think so.
We have to look at every aspect of the person's life, not just their time.
Right.
There's a lot involved. Yeah.
So if the person
your child or, as an adult, be treated or what have you? Is there a way for?
Yeah, treatment can't be compelled if you simply have a positive test and a negative chest X-ray because you're not a threat to anybody else. That's your choice. I can tell you, at the hospital where we screen a whole bunch of people and treat a whole bunch of people all the time, every day, I'd say 50% turn down the preventive treatment, and that's not that unusual. And remember that the lifetime risk of anything happening is only 10%, and of those, the people who would actually probably end up being a risk to others is probably like 5%, and that usually happens many years down the road. So I think of all the things that you all are anxious about, all of which I think are well-founded, I wouldn't worry that someone's going to end up being a threat because they turn down the preventive therapy. Our hope would be everybody who's found to have been exposed will accept preventive therapy, but we can't mandate it. Obviously, everybody ultimately has their own choice about whether to take medication. The only thing that you're compelled to do is be treated if you have active disease that could infect others. So you can be reassured that anyone else who's found to have active disease will be treated.
What are the risks of being allowing antibiotics? I mean, to be on.
Yeah, I mean, as with everything in medicine, yeah, the risks of as with everything in medicine, you weigh the risks and the benefits. So the benefit of being treated light years outweighs the risks. But it's antibiotic therapy for 6 or 9 months. So, you know, some people might be allergic, I might get a rash. Some people, liver tests may go up. I mean, you know, anything is possible. But as in anything in medicine, we wouldn't do it if it wasn't beneficial or unfounded. I mean, obviously, it's much safe if the risk of TB for an exposed person with a negative chest X-ray, which we might find several of, if their lifetime risk of developing TB is 5 or 10%, the risk of a medicine is far below that. It's less than 1%. So on balance, from a public health standpoint, it makes sense to treat. If the medicine was riskier than the risk of getting TB, we obviously would not be treating. We'd be doing it a disservice. Yeah.
I'd like to confirm that there will be some communication going home to all of the parents and guardians about what to look for, given that this person has been symptomatic for so long, so that we don't risk kind of having this gap of someone else getting infected. Audrey or Greg, will there be a letter going home tomorrow?
I'm wondering about the fact sheet that already went out.
Yeah.
So are you looking for symptoms of TB that parents should watch out for in their children?
Well, you know, if this person hadn't been symptomatic for the last 5 months, it might be a different story. But there could very well, as I said earlier, be a child in the school or another adult already infected, currently active with TB. And
so what information are you looking for?
For parents to be on the lookout for cough, fever, you know, that there's a chance that there is an infected child in the school.
So symptoms of TB that parents should look
and letting parents know how long this person had been symptomatic.
I think my take home from the earlier discussion with Eric was that, you know, maybe I would sometimes send my kids to school with a cough. Maybe his temperature was 99 last night, but it's fine this morning. I'm going to send him off. But maybe now I'll keep him home. I think that was a precautionary measure that I thought, oh, that makes sense at this time. So maybe some kind of guidance that way. I mean, that's my sense, right? I don't know what the research says or what the guidance, but maybe some kind of informed research about what really might make a difference in kind of not exposing other kids and also protecting our kids from not being exposed. Something like that.
It does sound like the index patient obviously didn't have a fever for the last 7 months, right? They were fairly mild.
Index patient what?
They didn't have a fever for the last 6 or 7 months, presumably, and come to school every day, right?
Hope not.
Hope not.
So, because we did hear a little bit of, well, you know, obviously for kids sick at home, feeling horrible with a fever, you don't send them to school, but we're talking about an illness where that apparently, at least in this instance, wasn't even the case, right?
This entire community, I mean the school, is starting tonight, obviously going to have a heightened awareness of this. And I think prolonged cough, losing weight unexpectedly, loss is really a hallmark of tuberculosis. If your body's fighting TB, you tend to lose weight. Fever, maybe could be low grade, night sweats. You know, I think for someone who's
has been kind of chronically ill and the docs are giving antibiotics and not getting better, I think we all need a heightened awareness that, gee, there was a case of TB at the school. And, I'm not sure the pediatrician knows that, or, we need to talk about it. There clearly needs to be a heightened awareness. It's just tough in the middle of flu season because there are going to be plenty of people with fever and cough who don't have tuberculosis. So, again, what distinguishes TB is the chronicity of it that doesn't go around. So.
Yes. I think what we're all trying to say is that there was somebody in the school since, as you say, since August, that if you're saying, that we should be more aware of our kids being sick, well, here's this person who's an adult who's in school since August to now, who had some sort of symptoms throughout this whole thing, and they never took themselves out of the school until Friday. So our concern is now we're the ones that are on heightened alert, but how many other kids, like myself, like I kept my daughter home today because she had a wet cough. I kept her home not because I was worried that she had TB. I would kept her home because I thought the other kids would think she had TB. Normally, I would send her to school. She has postnasal drip. She has no other symptoms. And that's what I think everybody is concerned about, is that all of a sudden now, just because that one person had the luxury of continuing to go to school and teach and stay in their job because they were mild symptoms and she could work or he could work through them, we now as parents, and some parents who both work, are now in a situation where if I send my child to school and they have postnasal and they have a cough and it's all day long, are they going to get a phone call from the administration of the nurse, or are they going to get parents sending information to them saying, why'd you send your kid to school? So that, I think, is a major concern. So I guess it's like, what is the protocol for that? How do we make sure, how do we alleviate, my two older kids know fully well what's going on because the 8th grade emails last night, the texts that we're going through, were wildfire. And my daughter's like, I'm not doing this because somebody's got it. And I'm like, you're going. That's my answer for it. So, that's why I think we need to send out something specifically to all the people that work here and aren't part of 140 and say, these are what we look for, and this is the framework about how long, if somebody's had a fever for 4 days, go get tested. If somebody's had a cough for a week and it's not productive, or it is, just different symptoms other than just flu.
Right, I think we can definitely take that under consideration to provide you some more information along those lines. Definitely. And along with that, I have to say, I think right now I would feel, in a similar fashion. So not to minimize that at all. Right. And it really, honestly, what you need to do as a parent is what you already do, and that is, my child has a cold, they're congested, they've got a cough. You know how your child's colds go. If that's the way the cold goes, no, there's no reason to call the doctor with a wet cough for a day or two, just as an example. So generally how your child is doing with a cold, with a strep throat. Most of us know what the children look like when it's really a strep throat or a bad sore throat. So same idea. If your normal routine for paying attention to your child being sick and not getting better in a few days is what should raise your concern. Getting better normally, great. But as Kemper said, if your child, they're not energetic, they're not playing, they don't have an appetite. If that happens for 1 day or 2 days, or even 3 days, that's one thing. If that's been going on for a month, or the child, like Kemper said, is coughing and it's not clearing up, we have pertussis and other coughing illnesses, and again, pay attention to lasting symptoms or different symptoms.
this is something different. It doesn't cause a runny nose. It doesn't cause sore throat. They don't look like they have a cold. Won't go away. This is, you know, a form of pneumonia. It's a lung infection. You know, this is going to be something. And again, this is not anything we're expecting to encounter. This is something sick.
But I think just
this is something
these
different.
parents who have kids that have a cough or have,
right. So
you know, that just saying no runny nose, I mean, that's phenomenal because that's a huge thing.
Right.
Every kid, you know, a lot of them have runny noses when they cough. And so for me, I'm like, oh, that's good. You know, my daughter, the one that's got the cough, is the one that's got to get tested. She's in the high risk. She's been coughing nonstop for 3-4 days. And yes, is that normal? Last year she coughed for a month. So, but she has a runny nose. So now I'm like, okay, that's good. I tell my husband, don't worry, she's got a runny nose. That's not a symptom. That's the information that needs to go out to every family.
I just think, you know, again, unfortunately, for better or worse, we're all going to have to have just a heightened level of awareness. And whereas before, you might would have just said, you know, it'll run its course, you know, give them a couple days. But if it's like, if this kid's been sick for a couple weeks, and they're not getting better, I got to tell the pediatrician, remember, there was a TB exposure. The fact's a fact. And, you know, their tests were negative last year, but maybe they need to be repeated this year.
1, 2, and then 3.
I wonder if maybe sending something out, I know this is being filmed, and some parents maybe couldn't have been here. I know it was mentioned, but maybe sending something out and saying, hey, there's a lot of, because there's been a lot of great questions, a lot of great answers to clarify things, just with a link to exactly how you can watch this, or maybe there's, you know, I don't know if someone could put together, that might be harder because this has been going on for so long, this meeting, but sort of a bullet point of some questions that were brought up that maybe weren't necessarily in that initial TB fact sheet, info sheet, I don't know. But at least, you know, reiterating, yes, this was filmed, there's great information, here's the link, here's how you can access that, just to sort of back it up.
And there's also the CDC website, cdc.gov, or our health department website. They both have good information too.
If you just Google CDC tuberculosis, they have a lot of information geared towards patients and families.
It's pretty neat, and my wife and I are both struggling right now, whether we should even form a or, you know, what is this response going to be when we come back? It backs up and it's going on. I mean, it shouldn't be a forced issue.
So sounds afraid of needles and...
Yeah, the skin test is easier than the blood test.
Right. So is that, you want to maybe talk with one of us between now and then about what's the best way to handle that? Maybe, okay, we'll be as flexible as we need to be to work things out with you.